So let's dive right into this. The world has become more aware of how race plays a significant role in healthcare. I don't think any of us have not realized that over many events, in particular over the last 18 to 24 months. And I would argue that this is perhaps even more relevant in the world of multiple myeloma than almost any other disease right now here in the US. And I say that for what I often call the big 10 reasons. So I'm going to walk you through 10 reasons why I think this is so important in multiple myeloma. First of all, myeloma is the most common hematologic or blood cancer in African Americans. So roughly 13, 14% of the total population of the US right now are African American. But 20% of myeloma patients are African American. And I'm going to share with you why that is in a moment, because the disease is more common in this population and growing, such that we expect over the next 10 to 15 years that this will be close to a quarter of all patients with multiple myeloma will be of African American descent. And so we will explain a little bit of why this is happening, but you'll see the significance of this as we go through, because it's so important that we care for all patients with myeloma. The IMF has been committed to caring for patients with myeloma for over 30 years, and it is very important for us not to exclude any patient. This is driven by the fact that myeloma and something called MGUS that you may or may not be familiar with, which is kind of a pre-myeloma condition that I'm going to explain in a few minutes, is twice as common in this population. So the incidence, as we call it, or the frequency that we see this disease is twice as high in the African American population. So if you take a set of individuals who are African American descent and those who are not, you're going to see this disease twice as much in that population, more than twice as much as white Americans. And this is very important because it highlights how critical it is that we capture this disease early on. Not only that, it's not just twice as common, it's actually diagnosed at a younger age. And this will become relevant. We talk a little bit later about how we approach teaching doctors even about multiple myeloma, because we tend to think of myeloma as a condition much later in life. The average age overall is about 69 years, and in white patients even older at 71, but in African American patients 66, and in Hispanic patients even a little bit younger at 65. So it can present a little bit differently. Now, one of the most sad facts I'm going to share with you is fact number 4, which is survival improvements in myeloma have just not been as pronounced in the African American population. So we talk about myeloma as a success story in cancer. We have doubled and even tripled the average survival of patients just in the last 10 years. We've seen huge advances, and we're going to be sharing with you, without going into too much detail, some of those drugs that have really guided much of this, and things like stem cell transplants and clinical trials. And so we've seen huge advances, but for all the advances we've seen, we have not seen it to the same degree in the African American population. So for every almost 1.5 years gain for the white population, it's just been over half of that for the African American population, and that's clearly not acceptable. What's also not acceptable is that almost all myeloma patients have a long time between the symptoms they develop, that I'm going to share with you in a moment, and making a correct diagnosis. That diagnosis is delayed even more in the African American population, perhaps even as long as half a year. The average patient will see a family doctor 3 times for their symptoms of multiple myeloma before myeloma light goes on, as it were, to make that diagnosis. We're going to be talking about the great treatments we've developed in myeloma. One of them are what we call triplets. So that's 3 drugs used together, like a great combination. African Americans are less likely to get triplets. They're less likely to get transplants. Stem cell transplants, or bone marrow transplant, as they're sometimes called, is a really important part of treating myeloma. And we've seen over the years that Black patients have less access to transplants, and surely less access to clinical trials, what I call the 3 T's: triplets, transplants, and trials. These are 3 things that have really improved survival in myeloma over the last several years. And unfortunately, we have not seen African Americans have the same access to it. So as I mentioned, if African Americans comprise maybe around 20% of all myeloma patients, we see less than 8% representation in clinical trials. And that's overall in general. In myeloma, it may even be lower in the 4 to 5% range. So this is really a concerning fact. We also know that there are some biological differences, and I don't want to get too deep into the science here, but we know that not all myelomas are the same. And so we can determine how serious someone's myeloma is based on the genetics that we find within the cancer cells. So we look right into the cancer cells and find their genes. And there are certain genes that make the disease more aggressive and certain genes that make the disease less aggressive. And interestingly, African-American patients are more likely to have less aggressive forms of myeloma. So they're more likely to have something called translocation 1114, just means a little bit of chromosome 1114 joined together, and less likely to have things that we know are very aggressive, like what we call the 17p deletion, when you're missing a part of chromosome 17. And so one would think then that African-American patients should have better survival than white patients. But as I showed you before, we've not seen that. But I like to end on a little word of hope here, and I know it may not be easy to interpret these curves, so I'll make sense of it, is that when we've looked at big systems, for example, like the VA system, where at least theoretically, all patients, Black or white or any background, are given the same treatment, we actually saw that survival for African Americans was better. So what I just shared about the biology a minute ago actually does make sense. That when African American patients are diagnosed correctly, when they're given the appropriate treatments, they can actually do better than white patients. And historically, they've not done that, of course. And so that is the hope that we have. That is the goal that we have to improve outcomes of patients so that we can see that happen and not see inferior survival in African-American patients. And so what can we do about this? And this is towards the end of my first little presentation here on Race Matters. We all know that this is a complex solution, a complex problem. There's no simple way to describe this. We know that there are a lot of reasons why individuals don't have access, for example, to the triplets, transplants, and trials. We know why there are a lot of reasons why the diagnosis is delayed. There's a lot of lack of trust in the system. There's geographical disparities. There's a whole series of reasons. In fact, in my interview with Dr. Nuka, we're going to be talking a little bit about the work and the research we need to do to understand the problem. You know, as doctors and scientists, we always say you got to go with diagnosis before you can go with treatment, right? And we want to diagnose this problem. And we know that it's a huge problem. But we humbly, and I would humbly suggest that there are at least some themes of success if we're going to make the situation better. And I've put them into 3 categories here: something we need to do in the general community, something we need to do in the medical community, and something we need to do in the corporate and regulatory community. So in the general community, we need to increase awareness, educate individuals, advocate, and truly empower people to understand this disease, so that if you're here today and you're listening in and you hear what we're saying, and you think, you know, I know someone who has symptoms, or I have signs and symptoms that could be myeloma, that maybe you need to get to your doctor so that they can make sure that you don't have myeloma. If you know someone who has myeloma, supporting, or if you hear and you have myeloma, that we can empower you with the tools that you need to make sure your outcomes are better so that you can get access to these things. In the medical community, we need to educate better. As we're going to share with you a little bit, we need what we sometimes call cultural competence. This idea of treating patients in a way that respects their background and understands their background and relates to them in the best way possible. And that, of course, we do everything we can to facilitate access. And then at the regulatory and the corporate level, so within the pharmaceutical industry, within the government, we need to set the right policy. We need to set expectations. If African-American patients make up 20% of all myeloma patients, then they need to be involved in all of these decisions that are being made about drug approvals, things like this. And there has to be a real commitment. And I don't think this is possible unless we bring everybody together. And that's part of our role at the International Myeloma Foundation, at the IMF, to bring these individuals together. And I believe that we can do this and that we can make a difference as we go forward. Because the IMF has created our African American Initiative, which is under the umbrella of what we call our Empower Project, So we want to empower all patients. So we are doing work within the Hispanic community, within the those who live in rural areas, those who are uninsured. There are lots of different at-risk groups, but we're focusing today within our African American initiative to improve short and long-term outcomes. And the IMF has always been built on four big pillars of awareness, education, support, and research. Awareness and advocacy, education, support, and research. And so we want to do our very best to improve this situation.